I now want to introduce Dr. Sherrod Coley, who is a family physician at People's Community Clinic in Austin, Texas. And again, a reminder, please check out presenter bios. We'll send the link again. Lots of good information about all these presenters, more than I can say. And I'll turn it over to you. Thank you.
Great, thank you. Can you guys hear me?
Yes.
Yes. Okay, great. Thank you, Amy. It's an honor to be here today with such distinguished speakers. What I'm going to discuss today is an example of just one federally qualified health center that's built a program to address pain that's aligned with the best practices that are outlined in the Health and Human Services Pain Management Best Practices Interagency Task Force report that came out last year. And I just want to point out that this is one FQHC, but there are other models that exist throughout the country in both urban and rural areas as well. Before we dive in, I want to give a brief overview of FQHCs for those who might not be aware. Federally qualified health centers are individual nonprofit entities that receive Section 330 grant funding from the Health Resources and Services Administration to provide primary care, behavioral health, dental, and other services in medically underserved regions throughout the country. FQHCs must accept patients with Medicaid and Medicare, private insurance, as well as those who are uninsured via a sliding fee scale. FQHCs came out of the civil rights era and LBJ's war on poverty, so have a history of providing healthcare and other resources to historically marginalized and underserved populations. They're trusted members of their local communities, and there are over 1,300 health centers with over 12,000 sites nationwide, serving around 30 million people, thus making FQHCs the largest healthcare network in the country. FQHCs have added importance right now as millions of Americans have lost their employer-sponsored health insurance due to COVID-19. And as we'll discuss, we're at the front lines with regards to chronic pain and opioid misuse. Next slide. Oh, thanks. So People's Community Clinic, where I work, didn't start as an FQHC, but became one in 2012. The clinic was originally a free clinic started 50 years ago by volunteer doctors and nurses in a church basement to take care of students and others who didn't have access to health care. It grew and expanded and began to care for an increasing number of working Central Texas families. We're a patient-centered medical home as well as a community-centered health home, meaning we recognize that most of health happens outside the four walls of the health center. So we work in both the clinic and community to improve health outcomes. You can see our new building there on the right, which we moved into in 2016. Last year, we served over 18,000 unique patients, 85% of which identified as Hispanic Latinx, and 63% of our patients prefer another language, mainly Spanish. 41% of our patients are on Medicaid or CHIP, while almost half, including most of our paying patients, are uninsured. Next slide, please. So why did we build this program? To start, we have to understand the structural issues at play that lead to health disparities. And this could be like an entire talk on its own. I'm going to try and summarize it by looking at this map of Austin that's on the right, which shows life expectancy by zip code. Now, most of the west side of Austin has a higher life expectancy, indicated by darker greens, while on the east side, where our clinic is, and where many of our patients come from, it's much lower, lighter greens and pinks, and some reds even. Much of this stems from a series of ordinances culminating in the 1928 Master Plan of Austin, along with subsequent federal regulations, which deliberately displaced communities of color to the east side. After years of policies rooted in institutional racism that limited economic opportunities, education, access to healthcare, and often created significant trauma for individuals and communities, what you end up with is what you see here. And this is what we mean when we talk about social determinants of health, that the conditions in which people live and work play a significant role in their overall health. The adage is that your zip code matters more than your genetic code, and this is playing out on the map there. What we know about trauma, especially through data about adverse childhood experiences, or ACEs, is that it leads to higher rates of chronic diseases. And the more trauma that you've experienced, the more likely you are to have conditions such as high blood pressure, diabetes, or cancer, as well as depression, anxiety, substance use disorder, and chronic pain. Studies show that emotional pain and physical pain activate the same parts of the brain, and there's a lot of overlap in the neural pathways. So people who have experienced trauma, which are a large number of our patients, may feel pain on their own or can exacerbate physical pain that they may have. Additionally, many have financial issues, are facing eviction, have food insecurity, or have other needs that can increase their stress, anxiety, and ultimately pain. Now, one of the other major barriers here in Texas is that we did not expand Medicaid. The large majority of our patients with pain don't have access to imaging, specialists like an orthopedist or a rheumatologist, or even physical therapy. They definitely don't have access to the growing number of evidence-based non-drug approaches. What this means is that there aren't a lot of options for practitioners to help patients with their pain, and oftentimes opioids end up being prescribed, which we know doesn't have great efficacy for chronic pain. Now, we're lucky that in our clinic, we don't have a lot of patients who have been prescribed opioids for pain. We decided to build a program that effectively addressed trauma and pain as a way to improve patients' functioning and quality of life, but also to prevent people from ending up on opioids. In a lot of ways, this is a prevention program. And really, we had no alternative but to build it in-house, as is often the case in FQHCs. Next slide, please. In FQHCs, we have various funding sources, including money from the 330 grant, payments for medical and behavioral health visits from Medicaid and Medicare. In Travis County, payments from our health district to cover eligible uninsured patient visits, and some money from foundations. This creates our general operating budget, which pays for many of our programs, including things like nutrition and our medical legal partnership. Now, one of the big things that helped were two HRSA grants that they're noted, the AIMS grant and the IBHS grant. They were intended to address mental health and fight the opioid epidemic. These ongoing funds have allowed us to hire a care coordinator who is essential to the functioning of the program and add other elements. Now, these grants are generous, but still fairly limited and really only provide about 1 day a week of some of these non-pharmacologic services. And I'm going to talk about those in a minute. But it's a start. And again, these grants were approved from the perspective of taking an opioid prevention strategy. Next slide, please. So how do we know how to build this? When I joined the clinic in 2018, PCC already had a lot of resources, including a robust trauma-responsive integrated behavioral health department, nutrition and cooking classes, medical legal partnership, which I'll discuss later, and a partnership with our local Chinese medicine school, AOMA, which had been running student acupuncture clinics. And Dr. Mary Faria, AOMA's president and CEO, and I will be on a panel later, and she'll be discussing our relationship a little bit further. Really, we just needed to integrate the services that we had better and add a few additional pieces. I had experience building something similar at an FQHC in California and had been involved with the nonprofit Integrative Medicine for the Underserved, which for a decade has served as a place to share best practices around pain care in FQHCs and other safety net settings. In 2016, this white paper on the left was released by the California Healthcare Foundation, which reviewed how community health centers were attempting to effectively address pain and provide alternatives to opioids. What the white paper found is that the majority of clinics addressing pain had these features in common. Group medical visits, which emphasize community building and self-management, and we'll discuss more about this. Team-based care, including integrated behavioral health, which can address both pain, mental health, and substance use. Some non-drug approaches to pain, which are generally not reimbursable, but health centers were incorporating this in innovative ways. And buprenorphine for dependence and chronic pain treatment. And we haven't had to incorporate this one yet, but we may. Overall, these findings served as a template for our program. Next slide, please. In May of 2019, this groundbreaking report from HHS was released, and it confirmed and validated what we were building and provided us with a larger blueprint as we move forward. The report recognizes the need to take a patient-centered biopsychosocial approach. Since so many of our patients are affected by upstream psychosocial and structural factors, this is generally how FQHCs already operate. Next slide, please. I want to take a minute to discuss the difference between addressing unmet social needs and social determinants of health through this slide from Castrucci and Auerbach. At the bottom, you see downstream interventions, which is the typical care that's provided in a clinic. When we start asking patients about food insecurity, housing, or transportation, we're actually looking midstream at individual social needs, which is incredibly important. We should continue to expand programs that emphasize these and address these. But if we go further upstream and look to address the conditions that created the food insecurity, lack of housing, et cetera, those are the social determinants, and these are structural factors. So improving these generally requires policy changes at a local, state, or federal level. Next slide, please. At our clinic, we address all three levels. In addition to the clinical care we provide, we developed our own social needs screening tool called the People's Tool, there on the left, which is open source and anyone can use it. And it ties into various interventions that we offer in the clinic or outside through partner and community organizations. We've also partnered with Aunt Bertha to build an internal online resource here on the right, to connect patients to what they need. You can plug in a patient's zip code and what resources they're looking for, and it'll provide information about what's available in their area. We use the information we gain to improve clinical care, but also moving into the upstream portion of that last graphic to inform our advocacy work to improve the conditions of our patients and their communities. This is an essential part of what FQHCs do. If we can't create change upstream, we're just spinning in circles downriver. Next slide, please. One specific intervention I wanted to mention, because it's pretty unique and plays a large role in improving our patients' lives, is our medical legal partnership. This program offers on-site legal services addressing health-harming legal needs, such as unlawful discrimination, tenants' rights issues, benefits denials, and more. In terms of our patients with pain, if someone is being threatened with eviction, that will increase their stress and typically their pain. Thus, taking that stressor off their plate is very helpful. Furthermore, many of our pain patients aren't able to work and may be eligible for disability, so our lawyers can help with that process. Getting disability usually means getting a small monthly payment, which can help with financial stress, but more importantly, they're able to get access to Medicaid and Medicare, which then allows them to get the imaging specialists, physical therapists, et cetera, that may benefit their pain. We currently have 4 lawyers on staff, and they function as members of our healthcare team. And I'll say that now that I've experienced it, I can't imagine working without lawyers as part of our team. Next slide, please. Now, as referenced in the HHS report, it's important to work in an individualized, multimodal, multidisciplinary fashion. The report recognized 5 categories of treatment approaches, which you can see on the left: medications, restorative therapies, interventional procedures, behavioral health approaches, and complementary and integrative health. And at PCC, we offer something from each of these boxes from which patients can choose. What this does is allow the patient to work with the healthcare team to come up with an individualized program based on patient preferences using this expanded toolbox. Next slide, please. So this is how the program looks in practice. The animations didn't work out, but that's okay. A patient comes in to see their primary care provider, which would be in the middle. The PCP can prescribe medications or potentially do an interventional procedure like a joint injection if indicated. But they can also discuss the IPMP and if the patient would like a referral. The PCP can then make a referral over to the care coordinator out of CELI. She'll then contact the patient and let them know about all the different services within our program. The patient could then be referred to the different elements of the program based on their preferences. So that could be behavioral health, which is kind of up in the 1 to 2 o'clock position, which is where most of our patients start. It could be our medical legal team if there's a legal need that's impacting their pain, our substance use counselor if needed, nutrition or cooking classes, exercise, or acupuncture, including full body or ear acupuncture following the NADA protocol, which has been shown to be effective for trauma, stress, anxiety, and substance use disorder. Or yoga therapy, which is more than just yoga. It's a one-on-one application of specific yogic tools, including exercises, breath work, meditation, and more done in a trauma-responsive manner. Now, we were planning on adding massage therapy, but COVID ended up putting those plans on hold. But the other place where patients can get referred to is our chronic pain groups, which is the cornerstone of our program. Next slide, please. So for those not familiar, group medical visits are an innovative value-based model where patients receive their medical care in a group. A provider has a face-to-face visit, so it's billable, but there's typically more time for education, information about self-management, peer-to-peer learning, and connection. Group visits are increasingly being used in underserved settings where so many patients are lonely and isolated. When patients are able to come together and realize that there are others who are going through something similar, they often feel less alone and more supported. Patients end up willing to try things that they may not otherwise. They make friends in the group, and they hold each other accountable. As my colleague Michelle Steinberg recently stated, often in our current model of care, we attempt to extract the individual in a way that fails to address the healing nature of community. For our groups, we adapted a curriculum developed by Paula Gardner, a physician in Massachusetts who had received a PCORI grant to develop a program specifically in underserved settings. The groups are co-facilitated by a social worker, a nutritionist, and myself. And each session generally includes a nutrition and cooking component, a mind-body activity, some sort of movement, and most importantly, connection between group members. Now, one last point I'll make about groups is that it's a more casual interaction, which breaks down the hierarchy which often exists in medicine and builds trust. The health team learns more about the patient's concerns, as well as the inherent knowledge patients have around their own health. And this really fosters that patient-health team partnership that is central to shared decision-making. Next slide, please. The other key element of the program are weekly case conferences to discuss complex patients. All of the different folks I've mentioned in the IPMP come to these. Oftentimes, some of the first things we do are stabilize crises and address social needs. So our lawyer and social workers are key to the discussion. One really important point about these case conferences is that, like the group visits that flatten hierarchies between patients and practitioners, these meetings do the same within our healthcare team. Everyone has their own expertise that they bring to the table, and we learn from each other. When more people are comfortable sharing their opinions, you're less likely to miss something, and overall this improves patient care. It also improves provider satisfaction and mitigates burnout. No one person has to do it all, since we all work together to figure out what exactly our patients need. A few of our team members say that these conferences are the highlights of their week. Next slide, please. The program's less than 2 years old, so we're in the process of collecting data. It's pretty hard to truly evaluate pain because it is so complex. We're looking at pain and functioning, behavioral health and physical health measures, opioid usage, and ER utilization. But really, the ultimate goal is to improve quality of life. And we're piloting a tool called the Flourishing Measures from the Human Flourishing Program at Harvard. As several of my colleagues state, we're moving from what's the matter with you to what matters to you. Honestly, patients don't necessarily care about their scores on any of these metrics. They care whether they can get back to doing the things that they love. So that's what we're trying to accomplish. Next slide. COVID-19 has disproportionately affected our patients, most of whom come from communities of color. Many of our patients are deemed essential workers who work in jobs like construction or food service and can't work from home. So they're more exposed to catching the virus. Many have lost their jobs and are at risk of losing their housing as they struggle financially. Many have underlying health conditions that put them at higher risk from COVID-19, and many can't obtain health insurance. So they're very limited in the services that they can access. Given these factors and the fact that patients may be less mobile and more isolated during this pandemic, our patients living with chronic pain are more likely experiencing more trauma, stress, depression, anxiety, substance use, and ultimately more pain. Unfortunately, the virus has changed so much about how our clinic can operate. Normally on Wednesday afternoons, I'd be in our chronic pain groups. Instead, here's a picture of me from July when we were in the worst part of COVID, where I'm standing outside in full PPE in 100-degree Texas heat, swabbing folks in our drive-through clinic. Now, despite all this, there's so much more we can do, and it'll be interesting to see how everything shifts in this post-COVID world. We began offering virtual behavioral health, legal care, one-on-one yoga therapy, and substance use counseling visits. We plan on bringing back virtual group visits, nutrition, and more. We're looking at whether we can offer videos on demand for mindfulness, acupressure, or qigong, and we'll also be safely restarting acupuncture in the next couple of weeks. Next slide. In terms of challenges, we do have long waits for many of our services, including acupuncture. This is mainly because these services may be limited to a day a week since they're grant funded and not reimbursable in FQHCs, which is one of the biggest barriers to creating a sustainable program. And with COVID, as we start moving to virtual visits, we're recognizing, as mentioned before, that some of our patients have limited internet access or don't have a lot of experience with technology. And also we're losing that in-person connection, especially from groups, which contributed so much to healing. We'll see with time what works and what doesn't, and have to adjust as FQHCs always have. So I want to close with a couple testimonials. The first is from a patient named Fred, and I don't actually have time to show this video, but you'll have the link in the slides and you can watch it on your own. But I will point out that Fred, who has chronic low back pain and has had multiple surgeries, has taken advantage of our behavioral health services, medical legal services, our group visits, and acupuncture. Next slide. I might have to go to maybe one more. And the second is from a patient that we're calling Gloria, and it's translated from Spanish. Now, I'm not going to read the entire testimonial, but some things to note. Now, Gloria lives with chronic pain and had an aversion to meds initially, so was looking for alternatives. She thought physical therapy was helpful. She joined our groups and enjoyed being with other people. Therapy was really important to help with her self-esteem. She changed her diet, which she felt really helped, and began drinking certain herbal teas, which culturally was something she was comfortable doing, which was reinforced in our groups. She got more family support. And according to her, there really wasn't one thing that worked. It was a process and it required patience. But one line that stuck with me, she said, "But in the most difficult moments, none of these things took away my pain. What they did was help me support my body so that it could stay strong so that I can continue to face or bear my pain." We have to remember that people with chronic pain will likely still hurt. The goal has never been to completely eliminate pain. The question is whether they can overcome it and learn the tools to be more resilient, to still be able to live the lives that they want, to do the things that they enjoy. And that's ultimately the goal of this program. Next slide. And thank you so much for this opportunity to present.
Sherrod, thank you so much. That was just fantastic. And again, what we all need to hear today.